Well, good day, everybody. Thank you for joining. Um, it's a pleasure again to have Dr. Her from USC School of Medicine talk to us and give us a lecture today on office rhinology recent developments. Before we get going, I just wanted to bring a couple things to everybody's attention. Some of our colleagues in Ethiopia are having a difficult time right now because of unrest in the northern part of the country. So um, we're wishing them all well. And then some of our colleagues who joined Zoom with our lecture series currently have COVID. Fortunately, they're recovering. So I hope everybody's doing well. Take care of yourselves, take care of your families. Um, 2 days from now, we have a big holiday in the United States called Thanksgiving, and we've got huge numbers of corona cases. So people pay attention and beware and stay safe. Okay, with that said, I'd like to give the opportunity for Kevin to give his lecture and sit back and um, let's all learn something here today. Kevin, please go ahead. Thank you.
All right. Thanks so much for inviting me back, Richard. What I want to talk about today is office rhinology. So, at least in in the United States, these last couple of years have been a stronger push to try to perform more procedures in the office rather than the operating room, because the office is a lower cost venue compared to an ambulatory surgical center um, or the OR. And so there's been more developments technology-wise in terms of new ways of treating certain rhinological diseases. And so I wanted to just introduce you guys to these methods that have been approved here in the United States over the last 4 or 5 years. Some of you have probably already tried these, but I'm happy to discuss them if any of you have experience using these devices. I don't have any disclosures. So what is considered an office procedure? And so to me, these are therapeutic procedures that are performed in the clinic. They usually do not require sedation, and they usually take a short amount of time to perform. And so usually what they require is just some local anesthetic, either topical or through an injection. And most of the time, these are pretty well tolerated, but because patients are awake, it really depends on the patient whether or not they can tolerate the procedure, because you're performing these through the nose in a very small area to operate in, and the patient will need to stay still during the procedure. And like I said, the reason for this shift towards office-based procedures is because the office is a lower cost venue for healthcare delivery and does not require as many resources as a surgical center or hospital-based facility. And therefore, insurance companies have been incentivizing companies and payers to try to perform more of these procedures in the office. And so choosing the right patient for an office procedure is very important. Since office procedures are being performed on awake patients, patient selection is important because they have to be able to tolerate you putting instruments into their nose. And so usually the patients that I find that have the best success in performing these procedures are patients that already have a strong preference to avoid the operating room. I'm sure a lot of you have seen patients who say, I don't want surgery at all. And so for those patients, office procedures are are a good option because it's not in the operating room. And so a lot of patients are more open to the fact that we can perform these in the office. Also, patients that are poor candidates for general anesthesia. So patients that are older, have lots of comorbidities. Those patients generally are better candidates to try to perform in the office with them awake rather than risking, if they have a higher risk for general anesthesia. Also, highly motivated patients. You'll see patients who hear about these procedures and really want to have them done. Those patients that have already sort of made up their mind as to that they want to undergo these procedures, they're generally good candidates. Also patients that, in terms of their personality, those that have a more relaxed affect, who can tolerate debridements, tolerate nasal endoscopies pretty well, that's already a good sign that these patients will tolerate office procedures better than other patients. So what's the sort of setup? So how should you set up your room for a rhinology procedure in the office? So this is the way my office looks like. Basically sort of mimics the OR a little bit. I have my tower on one side. I have my cart on the other side where we place, instruments and stuff like that. Sometimes I'll have an assistant stand on this side to hand me instruments. And this has suction and everything like that. I don't have a navigation tower, but in some Other offices, you might have a navigation system if you're working on a frontal sinus or you're putting a balloon in a sphenoid sinus. You might have a microdebrider if you're removing polyps or doing powered instrumentation. So this is from a paper. This is what Dr. Satari does in Houston. And when I did fellowship, we also had a navigation system for certain patients. So what are the technologies that I sort of want to talk about today? So before 2010, that's when balloons, sinuplasties were approved by the FDA. 2010 is also when we had in-office CT scanners become more popular. And then 2013, coblation was available for inferior turbinates here. That's a technology that it's only been the last 7 years, but it's become very popular. Latera is a bioabsorbable implant that you use for nasal valve collapse. Clarifix is a procedure you can perform. It's used cryoablation for vasomotor rhinitis. Then Rhinology and Inferior are a device that was just introduced, FDA approved actually in the last year for nasal valve obstruction. So I'm going to talk about each of these, and we'll have videos and everything like that. And I really want to go over the data behind these to show you like what's the data that sort of supported their approval in the United States, and also what are the limitations of these devices. So like I said, so vasomotor rhinitis, so Clarifix is the first one I'm going to talk about. That's how we use a technology called cryoablation to treat vasomotor rhinitis. Latera is a bioabsorbable implant used to treat dynamic nasal valve collapse. And Rhinology is a bipolar radial frequency for nasal valve obstruction. And then coblation is what I tend to use for inferior turbinate hypertrophy in the office. So vasomotor rhinitis, this is very common. I see a lot in elderly patients, those that have a runny nose due to autonomic dysfunction. It affects a lot of people in the United States, about 30 million people. And obviously the most common sign is they either have some postnasal drip or they have a runny nose, but they don't really have any allergy symptoms. It's usually that's their most prominent symptom is the runny nose. And like I said, it's more common in older adults from what I've seen. And so originally, before Clarifix was around, the most common treatment options are an anticholinergic with ipratropium, antihistamine with azolastine nasal sprays. There have been some reports of off-label use of Botox injected into the middle turbinate or inferior turbinate to reduce rhinorrhea. And then obviously the surgical treatment in the past, or is still available, is video neurectomy. And so when these fail, the medication fails, a video neurectomy has been considered a surgical option for rhinitis patients because the video nerve supplies most of the parasympathetic innervation to the secretory nasal mucosa via the preganglionic parasympathetic fibers, which synapse at the pterygopalatine ganglia. And so when you transect the video nerve, it's been shown to correct the balance of autonomic input to the nasal mucosa. However, some of the side effects are that it can include a persistent dry eye symptom due to the collateral damage to the parasympathetic fibers to lacrimal gland. And so there's been also, we know that once it synapses at the parasympathetic ganglia, it has little fibers, the posterior nasal fibers that come off into the nasal mucosa, which you can see here. These are the posterior nasal fibers. And so there's been talk about affecting these nerves instead to prevent the injury to the parasympathetic fibers to lacrimal gland. And that's where cryotherapy sort of comes in. And so this is the device called Clarifix. And so what it does is it has a little membrane here at the end of this device, and here is where the cryo fuel is. And so basically it uses freezing cold temperature of cryotherapy to destroy or ablate target tissue that contains the posterior nasal nerves. And that basically relieves the symptoms of rhinitis. And the area of maximal cryotherapy injury is this membrane here, which fills with the fluid once this valve is turned on. And it has an insulated stylus here so that it doesn't cause any collateral damage to the nasal mucosa when you place it into the nose. And you sort of hold this in one hand and you hold your scope in the other hand to direct this into where you believe the posterior nasal valves are located. So there's a video of how this works. So usually you put this, into the nose all the way far back near where the sphenopalatine foramen is. And then once you put it in, you turn on the valve and the fuel will flow into the device. There's a patient, she's been, pledges placed in the middle meatus here. Once you remove this, is the left side. You see the middle turbinate right here. And so when you see the middle turbinate attachment right here, this is where the posterior nasal nerves are. And so you want to place the device and have it sit right in this area here. And so it's designed, the shape of it designs it to just slide right in. So once you get over this hump here of the inferior turbinate, it sort of just sits right into this crevice here. And then you turn on the device and it'll fill the membrane up with this really cold liquid. And then it causes a cryoablation just in this area here. Usually you hold it there for about 30 seconds. And after 30 seconds, you let it sit for a little bit. The heat, it'll warm up a little bit from the nasal mucosa and then it slides right out. And usually for this procedure, I first place a pledget, and then afterwards, I actually will inject, do a sphenopalatine injection with a spinal needle in this area as well. So what's the data behind this procedure? And so the main paper that supported its FDA approval was done by Peter Wong at Stanford. And basically what they did is they looked at 27 patients with chronic rhinorrhea nasal congestion for 3 months, greater than 3 months, with minimum subscores of 2 of the total nasal symptom score. So this is the total nasal symptom score. It's a validated symptom severity scoring system of 4 individual subject-assessed symptom scores for rhinorrhea, nasal congestion, nasal itching, and sneezing. And so they rate them on a scale of 0 to 3, and the maximum score is 12. And so patients were recruited from 3 centers, 2 in California, 1 in Texas, and they had to have at least a score of 2 for nasal congestion and rhinorrhea. And they were followed for 7 days, 30 days, and 90 days in the clinic, and they were given surveys up to a year after the procedure. And so what they found was that the total nasal symptom score decreased significantly at 7 days from 6.2 to 4.3, and then continued to decrease down on average to about 2.6, and eventually to about 1.9 at 1 year. And so, but the thing is, you have to remember that 12 patients were actually lost to follow-up by a year out of only 27 patients. So we would take that with a grain of salt. You know, obviously 1 patient was an outlier and actually got worse. But on average, it seemed like this effect seemed to last up to a year based on this study. And they also had, in their group, they had 13 patients that were confirmed allergic patients that had a positive allergy test, and 13 that were non-allergic. And you see that even when you stratify between allergic and non-allergic, they both groups had improvement in their symptoms. The largest reduction in symptoms were seen in rhinorrhea and congestion, you see here, when patients were stratified, and whether or not they were allergic or non-allergic. So these are symptoms that this device had the most effect on for these patients. So what are some adverse events? And so there was some small amount of pain associated with this on post-op day 1. So they rated a 1.19 on a scale of 0 to 5 on the day after the procedure. 44% reported severe ear blockage on post-op day 1. That decreased to 4% on post-op day 7. 7% had severe nasal dryness on post-op day 7. And 1 patient had epistaxis 27 days after the procedure. One of the adverse events that wasn't really talked about in this paper, but you hear about a lot at talks and stuff, is an ice cream headache. And so from what I've been told from providers that have done this hundreds of times, they say that about 25% of their patients develop an ice cream headache. I actually haven't seen a patient develop it, but basically it's a very just strong headache after the procedure. And so usually it's recommended that the patient stays in your office for about 30 minutes or so after the procedure, just in case they develop the headache. In that case, you give them Tylenol, ibuprofen, and some have actually recommended gabapentin as a way to treat the ice cream headache. And the epistaxis is actually a very real risk with this procedure. When fellowship, we did a patient that was apparently on aspirin, but we weren't sure. He didn't tell us, and we did the procedure, and he actually had epistaxis after the procedure, which wasn't able to be controlled in the office. So we had to take him to the operating room, and it was bleeding basically from that middle turbinate stump with attachment to the lateral nasal wall. And so that required a suction bovie and a bipolar to control it in the operating room. And so, you know, epistaxis is actually a very real risk. It's rare, but it's something that patients should be counseled on during this procedure. And so how do we usually numb up the area? So usually I use topical anesthetic with 4% tetracaine, but obviously any whatever you're most comfortable with should be fine. You don't always have to inject. I like to inject just for hemostasis, and also, I think it's beneficial for the patient, but there haven't any studies showing that it improves hemostasis or improves pain scores. But what I do is I inject 1% lidocaine, 1 shot of epinephrine. I use a spinal needle and bend it a little bit, and I inject it right into that site where sphenopalatine foramen is, about like 1 or 2 cc's right before the procedure, and let it sit there for a couple of minutes before I perform the cryoablation. The second procedure I want to touch on is for dynamic nasal valve clasp, and this is the Latera implant. And so dynamic nasal valve clasp is a common anatomic factor that contributes to nasal airway obstruction, and it impacts patients' activities such as breathing and sleeping. And so you see here, this is the lower lateral cartilage is here. You see that in this patient, when they breathe in, they have collapse of their nasal valve because the cartilage sort of buckles in when they breathe in. And so treatment options have traditionally included non-surgical management, such as nasal sprays, nasal strips, and those don't work, the surgical procedures. And unfortunately, non-surgical methods do not actually address the weakness of the lateral nasal wall for patients with dynamic nasal valve collapse. It just helps support the area. It doesn't really fix the problem. Surgical methods strengthen the lateral nasal wall, but they require the operating room, are invasive, costly, and time-consuming. And so for this reason, it's been suggested that nasal valve collapse is often underdiagnosed and left untreated despite its relatively high prevalence, because of the treatments available are pretty invasive, because you have to do a rhinoplasty, the batten grafts, etc. And so that's why Latera was sort of developed as like sort of intermediate option for these patients. And it's basically a bioabsorbable implant. It's composed of it's basically composed of the same material that we use in vicryl sutures. And it basically supports the lateral nasal wall and is stable up to 24 months. So you place it between the skin and the nasal bone. So you have the prongs here over the nasal bone, and you have the tip of the implant over the area of greatest collapse. And so before you take the patient, and when you're evaluating the patient and you watch them breathe, you want to mark the area where you notice the greatest collapse. And when you place the implant, you want to have the tip of the implant over that area. And it's basically introduced under local anesthesia in the physician's office using a delivery tool, which you'll see on the following slide. And the implant is minimally invasive, and it can also be placed during traditional nasal surgery. So a lot of, I've seen some providers, when they perform a septoplasty and turbinate reduction, if the patient also has nasal valve collapse, they'll place this during the surgery as well. So here's an example of an illustration here. So in the patient, when they breathe in, you see that the area of greatest restriction here is the intranasal valve. And when they breathe in, you see that they have nasal valve collapse. And so when they're breathing in, I would mark the area of greatest collapse. And then once you mark it, you can take your device and you're going to slide it in all the way over the nasal bone. Once it's deployed, it'll help latch on, so when you come out, it's not going to come out with the device. And then you want the tip of it overlying the area of greatest collapse. And so once you do that, when the patient breathes in, you're not going to have any more dynamic nasal valve collapse anymore. So that's the theory. So what's the data behind the results from the studies? And so the studies that's most commonly cited is this multi-center randomized controlled trial for this device. And so this is one of the few times we have a randomized controlled trial in otolaryngology. So it's pretty interesting to see. And basically what they did is they randomized an implant versus a sham procedure. A sham procedure is basically the cannula was inserted into the nasolateral wall, but some patients had the implant deployed and some did not. And so patients didn't know whether or not they actually got the implant or not. And this was conducted at 10 clinics across the United States in patients who had a nose score of 55 or higher. So nose score is a validated survey to evaluate nasal obstruction on a score from 0 to 100. So 55 to 70 is considered severe, and then 70 to 100 is considered extreme. So all the patients either had severe or extreme nasal obstruction. And all of them had failed 4 weeks of medical management, either with nasal steroids or antihistamines. And they had to have appropriate facial anatomy. So this is sort of sort of a vague criteria here. Basically, they had to have sufficient cartilage to support the lateral nasal wall, and they had to have a stable and reasonably wide nasal bone to stabilize the implant. And that's basically was provider dependent in terms of how they evaluated that. They were excluded if they had any history of sinus surgery, septoplasty, rhinoplasty in the last 6 months. And so they enrolled 137, and they had 64 in the sham arm. So these patients did not receive an implant, but they had the procedure performed as if they had an implant. 63 received the biodegradable implant. So what they found was that in the treatment group, 82.5% were responders, and 54.7%, which to me seemed pretty high in the sham control, were also responders. So what was a responder? A responder was someone that improved in one nose class from what they were previously. So all the patients in the study were either severe or extreme nasal congestion based on the nose score greater than 55. And so a responder was those that went from an extreme to severe, or severe to moderate or mild, right? And so 82.5% of patients improved at least by 25 points, basically, on the nose score in this study. But 54.7% of the sham also improved at least 25 points. So that's I thought that was pretty interesting. But there was a significant difference between the two groups. And so they also looked at them at 1 month and 3 months. And so this was a 3-month study. And what they found was that at 1 month, interestingly, there was no difference between the sham group and the treatment arm. Whereas at 3 months, there was a difference in the nose scores. So the nose scores on average decreased by 42 points, whereas the sham group was like by 22 points. Same thing for the visual analog score. So basically had them rate their nasal congestion on a scale from like 0 to 10. They found that there was a mean, or 0 to 100, I mean, and they saw there was a improvement in scores by 39 points in the treatment arm at 3 months versus 13 points in the sham group, but there was no difference at 1 month. So it seemed like the effect of the treatment probably is most likely at 3 months. But the question is, like, how long does this last? Because the study was only done for 3 months. Does this improvement in symptoms last more than 3 months? And so there was a follow-up study to that randomized controlled trial where they did a prospective multi-center non-randomized trial of 166 patients, and they followed them for an entire year. They had the same criteria. They had been nose score greater than 55. They had to have failed 4 weeks of maximal medical management, but they could have had the implant placed either in the office or under anesthesia in the operating room. And that's because they had some patients that had inferior turbinate reduction performed at the same time. And so the previous study, that was just in the office, and in this study, they looked at patients that had this placed in the office or under anesthesia. And so what they found was that the effect lasted for 12 months. So the nose scores improved and stayed improved for 12 months. So they had this change in 44 points to 46 points. It lasted all 12 months for all patients. And when they stratified them by Latera alone versus those that also had an inferior turbinate reduction, there was improvement. They're roughly the same, slightly higher improvement in the Latera and inferior turbinate reduction, but they lasted for 12 months. And so for those, patients that in the study were all either severe or extreme nasal congestion based on the nose score, so points greater than 55. And after 12 months, a majority of them were in the mild or moderate category. And so they didn't completely go away in terms of their symptoms, but there was improvement. And it's important to remember that in this study, there was no control group. This is just a prospective, non-randomized study looking at just patients that underwent the procedure itself with no control group to compare to. So what are some adverse events with this procedure? And so the papers reported a 4 to 5.3% rate of implant retrieval, meaning that they had to go and take the implant out. And so taking the implant out is not that easy. You have to make a small incision and then pull the implant out. I haven't had to do it before, so that's what I've been told. Whether it's very easy or not, I don't have experience doing that. Why people required an implant retrieval is unclear. It could be due to infection, it could be swelling, it could be due to the fact the patient didn't like it. It wasn't documented in the papers that I saw. 6.5% will report cosmetic nose change. So I think especially in patients with very thin skin, they might actually see if the skin is really thin, placing the implant might cause an indentation or a slight bump in their skin, and that could be something that patients will not like. It is associated with some pain. Some people might feel it like a foreign body sensation, and that might be a reason that patients will want to have it removed. And it also might be some localized swelling. And from the 12-month prospective trial, they reported that 75% stated that they would recommend the procedure to family and friends. And so that's important to know because that means 25% of patients will not recommend it, right? And so that's something to consider. So patient selection, I think, in this procedure is very important. All right, the third technology I want to talk about today is for nasal valve obstruction. This one, so nasal valve is defined by the cartilaginous nasal septum, the anterior head, the inferior turbinate, and the caudal end of the upper lateral cartilage. And this region is critical in the development of nasal obstruction because it's the narrowest part of the nasal airway. So any minute changes in diameter of the valve results in exponential changes in the airflow. And so surgical treatment of nasal obstruction most commonly consists of repair of devious septum, reduction of inferior turbinates, but there's recently been greater focus on treatment of the nasal valve and the nasal upper lateral cartilage here. And that's where this technology comes in. And so radio frequency, which is what the technology used by Latera and Rhinology, which is the device here, radio frequency can change the shape of the cartilage and cause transient softening of the septal cartilage in this area at temperatures of 60 to 75 degrees Celsius. And so the cartilage can still maintain its elastic properties for anatomical loading, but you can affect the thickness of this area with this device. And so this device uses a stylus that delivers temperature controlled radio frequency to the intranasal valve region. Basically, you can inject some local anesthesia in this area and also along the septum and the turbinate if you want, if those are areas causing obstruction. And you can apply the tip of this device to these areas to cause softening and retraction of those areas to open up the intranasal valve. And so in this patient here, you see the intranasal valve, they have this upper lateral cartilage is here. It's also probably have thickened mucosa over it. And what you can do is you can.
303 ثانية.
Sorry, someone have a question? Okay. So you can apply, basically inject some lidocaine in this area with epinephrine, and then you apply pressure with this device, and you hold it there for 30 seconds. So 18 seconds is a heating period, and 12 seconds is a cooling period for this device. You see here is apply pressure, and it will open up the intranasal valve. It's important to counsel patients that after you do this, there actually will be some swelling, like reactionary swelling after this, and so they probably won't see the full benefit or feel the improvement in their symptoms probably for at least a week or so. And so what's the data behind this procedure? And so there's a study that was used to obtain FDA approval for this device. What they did is they looked at 50 patients. They had a higher nose score than the Latera. They used the nose score greater than 60. And then the patients had to have nasal valve as the primary contributor to obstruction. And that's based on how the authors evaluated the patient in the office. And then they had to have either a positive modified or just a regular caudal maneuver to be included in the study. What they looked at was the 26-week nose score. And they consider responders to have a greater than 15-point decrease, which is a little lower responder criteria than the Latera group. But what they found was that the mean baseline score was 80 for the patients, with 46% noting severe and 54% noting extreme obstruction. And at 27 weeks, you can see it just decreases significantly over time. And so the mean change in nose score at 26 weeks was actually 55 points, which is much higher than the criteria of 15 points. And so this is basically about 26 weeks is about 6 months. So the question is, does this continue to last for more than a year or 2 years? And so they also did a follow-up study that was published this year. which they looked at patients at 2 years. And as you can see, they started at 80 points, and the improvement from 80 points down to about 20 points actually was sustained up to 24 months, about 2 years after the procedure was performed in this patient population. And so they had 39 patients, and they were able to follow 36 patients at 12 and 24 months. And so they also asked a bunch of other questions on quality of life for these patients. And they found that 78% reported less difficulty falling asleep at 24 months, 72% reported better sleep, 69.4% reported less waking up at night, and 64% had increased sense of well-being. But what are some, adverse events are still unclear. This is pretty new. I actually have not, I've only seen talks and seen some demonstrations of this device, but it's actually just approved earlier this year, I think, by the FDA. So I haven't had a chance to actually use this device. And so it's all just based on data that I read from these papers and also just from talking to other providers. But it seems like there isn't very many adverse events with this device. But I have heard reports that it doesn't work in everyone. And so some patients, even when this procedure is performed, they don't sense improvement. And so what type of patients those are, I think is still unclear, and further experience is necessary in order to determine who this works best for and who is not a good candidate for this. But based on these papers, obviously patients that have very high nasal obstruction scores, like greater than 60, and they have, if you notice that their nasal valve has significant obstruction, I think those patients obviously are very good candidates for this procedure. And lastly, I want to talk about inferior turbinate hypertrophy. So inferior turbinate reduction is commonly performed in patients with chronic nasal obstruction due to hypertrophy turbinates. So initial management for turbinate hypertrophy usually is medical management of rhinitis and control of allergies. But there have been several techniques developed for inferior turbinate reduction. The first one was actually described in 1882. And so these are some of the list of all possible. I don't think there isn't clear evidence that one is always superior to the other. But as you use turbinate resection, turbinoplasty, you can use monopolar, bipolar, you can use laser. There's been I've seen some poster presentations on using ultrasonic bone aspirator to reduce turbinates. I think in my practice, the microdebrider, submucous resection, as well as the coblation is the most common techniques that I use for turbinate reduction. But there is no clear superiority between many of these. But there have been studies comparing them, and you find that coblation versus bipolar, that coblation is less painful, less crusting, the outcomes are the same. Coblation microdebrider has been reported that coblation is less painful, but patient satisfaction is still the same. Laser is less painful and bleeding based on this study, but has better relief of obstruction for turbinectomy. And then laser and microdebrider, they showed improvement for mucosal hypertrophy in both techniques, but microdebrider is superior when there is bone hypertrophy. Which sort of makes sense because microdebrider can also shave the bone a little bit, while laser is more difficult to reduce the bone of the inferior turbinates. For me, I just use microdebrider in the operating room when I do turbinate reductions. In the clinic, I find that coblation is much better tolerated for patients in the clinic, especially if they have mucosal hypertrophy, right? So usually I can take a freer and you can push on the turbinate to feel how soft it is and feel how much bone there is. There's a lot of soft tissue, erectile tissue. I think coblation is a very good option in the clinic. It's very easy to perform. So turbinate coblation, obviously the patient has a very hypertrophied inferior turbinate here. Sometimes you have to make multiple passes. Turbinate coblation usually basically coblates a very small area around the wand here. So you place it into the soft tissue, submucosal area, and then when you turn it on, it heats. It vaporizes basically tissue within 0.5 millimeters of the probe, while minimizing the amount of heat that's dissipated, so it doesn't cause as much collateral damage. But because the heat doesn't dissipate very much, and it only vaporizes a small area around the wand, sometimes you have to make multiple passes along the bone here in order to reduce the entire turbinate. And so usually depending on the size of the turbinate, it'll make 2 to 3 passes. So here, this person is going in slightly above it to reduce this swelling of the turbinate. Obviously, the swelling is reduced, and it allows greater room for airflow through the nose. just coming out and reducing it more. Yeah, so usually you go in and you, because the tip of the probe is where the coblation occurs, you draw it back to certain lines here on the device, and you vaporize a little bit more, vaporize a little bit more, and it reduces the turbinate along its trajectory from the back of the nose to the front of the nose. So in conclusion, there are several options for treating rhinitis and nasal obstruction in the office that have been developed in these last couple of years that are just further options for your patients to consider when they have rhinitis or nasal obstruction. And so before it was more like you had nasal obstruction, so you receive medical management in the office, and if those don't work, then you go to the operating room to have procedures performed. But now with these office procedures, it's an intermediary option for patients that if they meet specific criteria. And so they don't always have to go to the operating room to have their symptoms improved. But it's important to remember that most of these devices and technologies and procedures that I talked about today are very recent. They've only been around for 4 or 5 years. So the long-term efficacy of these treatments are still yet to be determined, as well as the adverse effects. You know, most of these adverse events reported seem very minimal in these papers, but until we have a larger amount of patients that have undergone procedures, we'll really truly know what are the possible adverse events that are associated with these procedures. And that's it. Do you guys have any questions or anything?
Kevin, tell me something. Are all those probes, are they reusable or they're disposable after each case?
That's a very good question. They are all disposable.
What's the average cost of a probe like for?
Yeah, it depends. So I'd say for the Clarifix, it costs about $1,500. For Latera is also, they're all about like between $1,000 to $3,000. Rhinology I haven't used. Latera is about $1,500 per side. I haven't used Rhinology, so I don't know how much the probe costs.
It's a lot of money.
It's a lot of money.
Mm-hmm.
And right now, also the thing is right now, because these are new technologies, they're not necessarily, most of the time they're not covered by insurance. So most of the time, if patients want these, they have to be paid out of pocket. Especially for Latera, if you try to do a Latera implant during a septoplasty for turbinate reduction, most of the time it's denied, and so the patient has to pay out of pocket for it.
Mm-hmm.
But the thinking is that after these are used more often in the next couple of years, they'll be covered by insurance because for certain they're actually much cheaper. Obviously, surgery is much more expensive than if you did one of these to treat the same problem. But it's really choosing the right patients that's the most important thing.
Well, there's a lot of changes going on and a lot of things you can do in the office. It seems like the future has a lot more to hold for us. Anybody else have any questions?
Richard.
Yeah, go ahead.
I would like to ask Dr. Kevin if he only uses topical anesthetic or he does injection.
I do injection for all my patients. I think I usually spray. Well, before COVID, I would spray, but now I just use pledgets inside the nose. I'll just sit there for about 10 to 15 minutes. Then I inject afterwards. I think that has the best effect in terms of numbing the area. From my experience, I don't know of any study that's compared topical versus injection. So I think that's still the debate still out there. But from my experience, I tend to apply topical and then I always inject.
Thank you.
Okay, unless there's any more questions, Kevin, thank you for your time, and everybody appreciates it. I learned a lot of new little techniques, and as much as I don't do rhinology, but the coblation of the inferior turbinate seems like it's a much nicer procedure to do than some of the other ones that we used in the past. So
yeah, there's been a lot of turbinate reduction has changed a lot, and a lot of new techniques have been introduced in the last few decades.
So,
it's just more
do you ever see you ever lose turbinates with coblation?
Do you ever what?
Do you ever lose them? In other words, do they ever necrose and literally fall off?
No, I've never seen that before. It's such a small area that's vaporized. And usually I've never seen it penetrate the mucosa. It's always some mucosal. And so I've never seen necrosis of the turbinate. because usually the vasculature, the infraturbinate usually runs on the inside of the infraturbinate, and usually when you do the coblation, you're on the lateral aspect of the infraturbinate. So I think it's very rare to injure the vasculature and cause necrosis.
Great. Okay, if there's no more questions, Kevin, thank you. Everybody have a nice week, and we'll rejoin next week. Thank you, Kevin.
All right, thanks so much for inviting me. Everyone stay safe.
Okay, bye-bye.